Hello, everybody. Well, thank you all so much for coming. It's wonderful to see you here. My name is Valerie Phillips.
Bob Parker, RQHR.
And you've probably gotten at least one email from each of us pertaining to this event. Just to open, I'd like to acknowledge that we are here on Treaty 6 territory at the homeland of the Métis, and we'd like to pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship to one another. So today we have a really interesting and action-packed day ahead of us. There is a program in your folders that has the agenda and also has the bios of all of the speakers, so I would encourage you to have a look at that. And Bob will tell you about the WebEx.
So we've been fortunate enough to be able to set up a WebEx option. So welcome to all of our WebEx participants. There is not a dial-up option for call-in for the WebEx. It's by chat only. So if you have questions, please send them through chat and we will address. Questions from the attendees will be asked first, and then we will either ask the questions or save them for the interview panel in the afternoon. If there is time during the presentations for individualized questions, we just ask that we will bring a mic to your table. Just give us a wave and we'll come over, because otherwise we'll have to have you repeat the question so that the participants on WebEx will be able to hear the questions as well. So it'll just save us a little bit of time if you just use the mic off the beginning.
Great, and also with regard to questions, not every speaker may have time to take questions at the end of their presentation, but we've built in a Q&A with all of our 4 out-of-province speakers towards the end of the day. So feel free to kind of hold your questions for that. As well, on each of your tables, there are a few pieces of paper that look like that, and that allows you to jot down your responses to any presentation. We will collect those and we'll use some of those ideas in day 2 tomorrow. Finally, another housekeeping, in the interest of your comfort and safety, the washrooms, you probably passed them on the way in. They're through those doors and up the little ramp. And should we need to be evacuated from this building, the fire exit is also up the ramp and right out onto the street. We also have Wi-Fi. I'm sure that during the presentations you'll be riveted to what's going on up here, but if you want to check your email during the breaks, it's Antimicrobial, and then the password is November 2017. Anything else?
So just a double reminder with regards to your questions. If there isn't time, we just ask that you even just use the back of your scratch notes. We'll pick those up in between the presentations, and that will help us as well for the interview panel and getting some questions generated. And I think, yeah, that's...
So now, it is my pleasure to introduce Saskatchewan's Chief Medical Health Officer, Dr. Saqib Shahab.
Thanks, Val. So, wow, what a great turnout on a snowy November morning. I think it's really exciting that so many people signed up for this really important symposium. And thank you, Rob, for also opening it up for WebEx, because for many of us who have lived and worked in rural Saskatchewan, we can't always make it in terms of attending face-to-face. So while there's nothing like face-to-face, being able to catch sessions during the day and tomorrow, and also being able to view them afterwards as recordings is, really important as well. So thank you for facilitating that as well. We, all of us, I'm sure, are looking forward to learning from each other and from other experts who've come from throughout Canada over the next couple of days, and to see the progress we have made and others have made on antimicrobial stewardship. And like many things in health and public health, while we have to think global, we do have to act locally, and that's why these kind of symposiums are so important. I was just chatting with colleagues at my table that many of us who have also traveled and worked overseas, we do appreciate what we have here in Canada. Many low and middle income countries don't really have the resources that we have in terms of antibiotic stewardship. And many parts of the world still have not reached the per capita usage that many high-income countries have. But still, you can see disturbing signs of antibiotic resistance emerging, both in human health and animal health. So again, it's really important to learn from each other and to also have a global eye on where things are going. A lot of emphasis on antimicrobial stewardship now by the World Health Organization. It was a keynote item at a recent UN meeting. So that really demonstrates the international and global importance of this issue. Climate change, antimicrobial resistance, these are all hot topics right now. If you look at the recent CPAS report that the Public Health Agency released, Canada overall seems to be doing well, and even from the OECD report, I think in 2016, we seem to be near the top or the middle of the pack in terms of antimicrobial stewardship and use, which is really good. In the CPAS report, Saskatchewan still seems to be on the higher side, so it'll be great to learn from speakers today and tomorrow about, where are we doing well, where's some opportunities for improvement, and how can we monitor that over the next few years. And again, just talking to colleagues just this morning, I've learned so much about great initiatives that are happening locally. Over the last 10, 15 years, we've obviously seen great work happening at tertiary care centers, at regional hospitals, but linking some of that to primary care is going to be key, and I think there's some really exciting initiatives in Saskatchewan that have happened, both in urban areas as well as rural remote areas in northern Saskatchewan that'll be so important for us to learn from. And really take advantage of our transition that's happening into a single integrated health authority in terms of replicating our successes, Saskatchewan-wide. The other thing, when I was, Valerie sent around an Excel spreadsheet with all the attendees, so it was really great to see people attending from so many sectors, both human health as well as veterinary medicine, and patients as well. Because it is intersectoral. Antimicrobial use, stewardship, responsibilities to prevent emergence of antimicrobial resistance, it cuts across sectors, including health, agriculture, veterinary medicine. And these connections and the One Health nature of antimicrobial stewardship means that all of us have to work in this together. And again, there's been some landmark achievements that Canada has made in that, in both human health and animal health, and I'm sure we'll be learning more about that in terms of the framework that the federal government has initiated, but that really is a national strategy. And in a federated structure like Canada, I think it is really important to have that framework, but then all of us contributing in our own jurisdictions. Another thing that we have made great progress, but lots of space for improvement, both provincially and nationally, has been good data to monitor our progress. The data can include antimicrobial resistance patterns, so lots of good stuff like antibiograms coming up. We'll be hearing a lot of that tomorrow. Prescription volumes and appropriateness. Again, one has to understand what does that mean, and I think there's a workshop tomorrow about that, about how units are used, what they can mean and what they cannot mean. We've done a lot around infection prevention and control indicators for antimicrobial resistance pressure in hospitals, long-term care. Need to do more, certainly, in the community, and to also monitor trends across sectors and how they impact or don't impact one another, and address some of the truths, but also some of the myths around antimicrobial resistance, because at the end of the day, antimicrobials are essential. We can't demonize them. They are essential. They are life-saving. They are important. They have to be used appropriately, but they also have to be used responsibly. And again, this just shows how we've had a long tradition of a collaborative way of work, and that is across disciplines like infectious disease specialists who are here, medical microbiologists, the lab network, public health physicians and practitioners, our network of infection prevention and control practitioners. Again, we've seen tremendous growth and that field in Saskatchewan over the last 2 decades. And again, that's really important kind of network that keeps us all aligned and on the right path for antimicrobial stewardship. Practitioners from all disciplines as well as the regulatory colleges. So we have the colleges of physicians, dentists, pharmacists, nursing participating. So again, all important partners as well as academic detailing, powerhouses like RX Files, frontline providers, patients. So many of them are attending this symposium, and all of them need to work collaboratively to address this. And like I said earlier, while we are developing a national approach, it has to remain locally and contextually relevant. And I was looking through some of the presentations that we're going to hear from today. And there is really relevant, contextually relevant work that has happened in Saskatchewan, for example, in northern Saskatchewan. So, I'm really looking forward to see how a lot of the science and the surveillance and the indicators become meaningful at the provider-practitioner level. And finally, Valerie, Phillips, Rob, I know you've been working hard with colleagues in the regional health authorities and with the Public Health Agency of Canada. So thank you once again for organizing this. Thank you for inviting me. This gives me an excuse to attend this for at least today and possibly tomorrow if the weather becomes really bad. And I'm really looking forward to hearing from the presentations today. Thanks.
Thank you very much, Saqib. You've given us a lot to think about as we embark on today. Now I'd like to introduce Heather Thiessen, who has been a patient family advisor for over 6 years, I think, in the Saskatoon Health Region. And so even though she's based in Saskatoon, Heather and I have had occasion to work together because she's involved in a number of projects. So for a patient's perspective, please welcome Heather Thiessen.
Ready to go? Okay. Good morning, and thank you so much for inviting me today. This wouldn't be a Heather presentation without first telling you a little bit about myself, so we're going to start. And so I'm going to introduce my family to you. My wonderful husband, John, we've been married for 25 years, and my 2 amazing daughters, Anna and Paulina. Didn't start off thinking I'm going to be a patient for my life and help change the world that way. No, I was actually in nursing and was pretty excited about that. And unfortunately, when I started nursing, I started falling and started being really tired and having sensory issues and vision problems. And I was diagnosed with multiple sclerosis. So I had to reevaluate my life and dropped out of nursing. Hardest decision of my life. But I was able to carry on, get married to John, worked for an insurance company, and I did long-term disability claims and had Anna. But shortly after Anna was born, I started going into respiratory failure, which really baffled my doctors because usually people with MS don't go into respiratory failure. But that carried on, and they thought, well, maybe Heather has a high lesion, we'll just carry on. But I saw a lot of ICU time. And it was after the birth of my daughter, Paulina, that the doctors started looking a little closer at me. And they realized that, and it was Dr. Hayter, he was called in and he said, have you ever noticed that her bigger muscles are fatiguing quicker than her smaller muscles? And they went, oh, yeah. And they did a CT scan, and they went, this woman has, her thymus has grown into a big tumor. And I was diagnosed with another neurological condition called myasthenia gravis. So I was pretty excited because I thought, well, maybe the MS isn't going to be as bad as we once thought. But I didn't realize the incredible journey that having myasthenia gravis was going to put me on. And so from 1998 to 2009, every 6 months, that was my reality. I would come into emergency very sick in a myasthenic crisis, end up in ICU on a ventilator, and go back home and then repeat. I seemed to pick up every bug that my child would bring into the house. And so my immune system was quite low, and I would pick up everything. Now, the interesting thing about this little reality that I was facing is that every time I came into the hospital, though, I was the only one that really knew my whole story. Although I was never, ever asked what I thought about treatment plans or what we should be doing. And often I would come into ICU and they would just start antibiotics and we wouldn't discuss it. And now today, I'm only able to take probably 1 or 2 antibiotics safely. And so now we're very, very careful about what I take. I've been very, very fortunate, though, to work with some very incredible physicians who have actually decided to partner with me in my health care. And that is the key, is the partnership with your patient and having those critical discussions with them. And so I'm going to give you a couple examples of what we have done together. So in my early days, I had the wonderful neurologist, Dr. Carol Boyle, who's since passed away, and that was the saddest day of my life. But Carol Boyle was a scary lady because she was tough, but she understood me as a patient. So I forgot to tell you, so I have MS, myasthenia gravis. I also have a life-threatening latex allergies. So if there's balloons in here, please get them out. And I also have many drug and food allergies. I am a nightmare of a patient, but as I tell to students when they have to work with me, I'm super nice and I want to collaborate with you, so we'll get along great. Dr. Boyle knew this and empowered me as a patient when I would come into the hospital very sick. She would say to all the residents or pharmacists, healthcare providers, anyone who's working with me, you listen to Heather. She knows herself the best, and she will help keep you from killing her. That was huge to me because very many mistakes were made on me, from inappropriate use of medications, going through rubber stoppers, and then injecting that into me would throw me into an anaphylactic shock. So I became very vigilant about what and who were putting things inside me. Thankfully for those conversations, though, she instilled this with other physicians. And so when we were able to start asking questions of why were we using this antibiotic? Because of my reality now, we should have done those questions earlier. Was this appropriate use? Should we have done this at the time? Could we have waited? And sometimes with my case, we can't wait. So it's kind of throwing balls in the air and wondering where they're going to go. And that's how I live my life. Dr. Boyle, though, did instill into other physicians who are now in my care, and that's Wendy Fitzpatrick, who is now my neurologist. And just last September or October, I came into the hospital in a myasthenic crisis. I had pneumonia that was undiagnosed. My family physician thought, unfortunately, I had intercostal muscle issues, and I had full-blown pneumonia, and I was very sick by the time I came to the hospital. Dr. Fitzpatrick stepped on every toe to make sure I was safe and got me the treatment that I needed. But then they found out, well, she has pneumonia, and the physician in charge said, well, let's just wait and see what happens. We can't do that with Heather, because that would throw me into ICU, and that's a whole new ballgame I don't want to deal with. Dr. Fitzpatrick stepped up, and she said, no, we have to start this now. I'm here today because she stepped up, and my time in the hospital was shorter. Thankfully, she understood that we needed to start the antibiotics. But another example I'd like to share is my daughter, Anna, because she came home in October at Thanksgiving with a sore throat. This kid gets chronic sore throats and is always dealing with them. So I just say, gargle with salt water, that's your best friend. But it got really bad, so she went into a walk-in clinic. She shouldn't have done that, but she did. And the physician didn't even do a throat swab. He just said, oh, well, you have strep, threw her antibiotics. And she started to take them, didn't discuss with her at all, which I was so sad about. And she didn't get better. She got kind of worse. And the problem is that she didn't have strep, she had a viral infection. And that antibiotic wasn't useful. And now my fear as a mother is that she has been given this a couple of times inappropriately. And my fear is that she's going to become like me and down to 1 or 2 antibiotics that will work when she does need it. So why am I saying all this? Is that it's so important to have discussion with your patients and your family members that are with them. And it starts with your family docs and your specialists and really bringing in and partnering with your patients. It's so important to have us as partners in everything. I'm thankful for those doctors who would work with me and educated me on the appropriate use of antibiotics and willing to risk relationships like Dr. Fitzpatrick did because she knew what was right to do at the time. She knew me well, and she also knew by talking to me that I was very sick. It's vital that we have these discussions and changing the public's perspective of what it is. Unfortunately, today, so many people are just coming into the doctors and saying, just give me antibiotics. But we have to stop that and say, why do you think you need it? You don't need it as preventative, you need it to save your life. And it starts with you all here today. So I'm excited about the presentations that will happen today. They're going to help inform you. We have to change the culture, and that's how we're going to do it. It's the culture of physicians working with one another and their teams. It's the culture of working with your patients and really bringing them in as partners. Once you do, amazing things happen, and it will change the way that things are done. So thank you very much. Have a great conference, and we'll see you all soon.
Thank you very much, Heather. Heather's story really hit home for me how treatment is so individual, and that it's the foundation of good treatment is good communication and finding stuff out. Bob is just bringing up our next presentation, and I'm very pleased to introduce Dr. Lynora Saxinger, who comes to us all the way from Edmonton. And Lynora is an academic infectious diseases specialist and has a whole ton of street cred, which you can read about in her extensive bio. But we had the idea to invite her because my colleague from the Ministry of Agriculture, Wendy Wilkins, heard her speak at the Alberta One Health Conference a year ago and said that we had to bring her in. So thank you very much. Please join me in welcoming Lynora.
Good morning. I was very honored to be asked to speak, and I kind of have a Swiss Army knife presentation that has a few too many slides. I'm going to expand and contract to fit the time based on, I guess, interest and applicability. So to get an idea of interest and applicability, I just kind of want to get a sense in my head of who we have here, and in no particular order, I'm going to ask you to raise your hand if you're one of these people. So are you a physician? Okay. Are you a pharmacist? Okay. Are you an infection control practitioner? You guys got it going on. You got everything. Are you a healthcare administrator? Okay. Who did I miss? Nurses? Yeah. Yeah. So nurses kind of some overlap with the ICPs. Okay. And laboratory. Okay. All right. Thanks. The title of my talk, actually, or the image, is The End of an Era. And I don't think that it's actually incorrect to say that we're at the end of the antibiotic era as we know it. I'm going to do some kind of big picture stuff, and I'm also going to get fairly granular as we work through it. And the end of the era part is interesting to me, and I think that we really have to think critically about what we do right now, because history will judge us harshly if we screw this up. So my goal is to talk about some big ideas, introduce and explore a couple of concepts, survey the current landscape a little bit, and then start to focus on both the why of stewardship and also a little bit on the how of stewardship. I do talk about AMR a bit. My human health lens is really kind of riffing on the previous One Health talk, but it's really not going to be a big part of this. I think I've decided to let some of that material go on the One Health side and talk a little bit more about human health system approach. We're going to talk about the two main approaches to antimicrobial stewardship. My setting is mostly acute care stewardship, but I really do have to say that most of the antibiotic use in Canada, 93%, is in outpatient pharmacies. And so we can't forget community stewardship as well. I'm going to talk a little bit about accreditation, because things really change in accreditation when you become one health system, because we are one in Alberta as well, and we learned something from that. So there's some considerations there. So I'm now showing you a picture, probably from a video game, of a medieval hall and an Anglo-Saxon mask. Now, before you really get tangled up trying to figure out why I'm doing that, I'm just going to talk about the root of the word stewardship. So steward is a title. It's a title of someone who actually is the keeper of the hall for the community. And so the concept and the usage of this term over history has had everything to do with keeping the hall for the community. And if you lived in a hovel and there's nothing good in your life except for drudgery, the only good place to go in your community was the hall. And so that keeper of the hall probably got a lot of abuse, but also a lot of respect, because they were doing a very important job in their community. And so when we think about stewardship, I actually don't think about air hostesses necessarily. I actually really am thinking about keeping the hall of the community and how important that is, and how that actually has been, a foundation of trust. And that's really what we're talking about when we talk about stewardship. And that's for any kind of stewardship. And in antimicrobial stewardship in specific, when I give talks at vet conferences, we get the situation where the animal people and the human people are looking at each other like, you're the one doing it. And in reality, I'm not going to spend a lot of time on this, but this slide basically tells us where the human health system is in the whole scenario. So for humans in the community and hospitalized patients, that's where the antibiotic stewardship has to happen, because that's where the use happens, and that's where basically the antimicrobial resistance of concern to people really happens. The impact of animal antimicrobial use on human medicine at this point is fairly indirect. And although all of these things within the environment and within like One Health as a whole is important, we have to look after our stuff first. Because that's really where, when I see people with resistant organisms in hospital, it's because of what we have been doing with that patient all along their healthcare journey. And so that's an important thing to recall as well. So results of antibiotic use, lives are saved. This is not a zero-sum game. We can't reduce antibiotics. It's not like you're trying to control crack or cigarettes, which we can argue are probably pretty much bad across the board for people. Antibiotics save lives, and so we're trying to reduce a fraction of unnecessary use, and defining that becomes very, very difficult. Quicker healing is another benefit, so even if your cellulitis wasn't going to kill you, you get better faster with an antibiotic, and people like that. The other thing is people don't know that the cellulitis won't kill them, because our entire culture has become used to an antibiotic for an infection. So they don't know that in the bad old days you'd just be laid up for longer. Other results of antibiotic use are infection with resistant organisms, ranging from difficult through impossible to treat. I didn't think when I started my career in ID a long, long time ago that I would see basically MRSA as such a predominant pathogen. It was still kind of a news headline when I started. And carbapenemase-producing organisms have also become very commonplace in the healthcare setting. Many of those carry other forms of resistance and are really, really hard to treat. Occasionally I get a report where the first report from the lab has nothing but resistance listed on the antibiotic list. This is not something we like to see. Increasing problems, Canadian data tells us that there's a case of C. diff for every 172 patients admitted to hospital. This varies a lot from place to place. 30-day mortality is quite high, and it increases length of stay by 11 days. So if you're trying to run an efficient healthcare system, this is a disaster. There's been a 17-fold increase in MRSA from 1995 to 2010. There's pretty high mortality with MRSA, well, staph aureus in general, but MRSA in particular, and increased length of stay as well. And our carbapenemase-resistant organisms or carbapenemase carrying organisms have increased by 33%. And in some settings, the mortality of those is very high if you're actually infected, not just carrying. So it is a changed landscape already. And the costs of these things are significant. Now, like everything in public health, success is silent. So if you're preventing costs, it's hard to say how much you're actually saving. So that's one of the things that we have to think about when we think about metrics, is how do we count these things? So I'm going to talk about a case. It's a 22-year-old woman with fever, pelvic pain, chills, and rigors for 3 weeks. Onset after the birth of a healthy baby girl. This was her first baby. Exam, pale, delirious, palpable mass in the right lower quadrant. This is where you start to wonder where I got this case. An exploring needle is attempted into the mass, and blood is withdrawn. Patient develops a thready pulse, became obtunded, and died. This is actually a real case from 1889. It was a 22-year-old woman having her first baby with a postpartum complication that resulted in sepsis and death. So that's what could happen. That was a fact of life at that time. So another thing to remember is, why do we die? In 1900, there was this great interactive thing on the New England Journal website, which they've taken down now, but you could basically look at things in different ways. And so the number of deaths per 100,000 were about 61% infection in 1900. And in 2010, it was 7.4% infection. So we've done a lot. We've done a lot. We're doing much, much better with infections. And that's probably one of the problems, is that people feel safe and confident and better with antibiotics because they made a big difference to our society. Antibiotic discovery was just crazy in the 50s, 60s, 70s, early 90s. Things started to taper off. There hasn't been any new registered classes of antibiotics discovered since '87. There probably are going to be some changes because there's some things in the pipeline now, but really everything that we've been doing since then is riffing on stuff we already have, which is, from a pharmaceutical company point of view, quite good because you don't have to do as much R&D. From a bacteria point of view, it gets a little dodgy because you're basically just giving variations on a theme, and resistance can be a problem. So until 70 years ago, it was mano a mano, pathogen versus immune system, you lived or you died. My father's father died of community-acquired pneumonia at the age of 36. Hale and Hardy volunteer fireman guy died of pneumonia. We don't see that happen very much. Antimicrobials come in. People want to put them in lipstick, laundry soap. Seriously, they were like, it's time to close the book on infectious diseases. This problem is over. But within a couple of years, we actually started to see resistance to the antibiotics. Why is that? Well, right now you're outnumbered by your own bacteria, if that makes you feel any better. So there's 5 to 10 times more bacterial cells than your cells in you at the moment. There's about a 20-minute versus a 20-year replication time, so lots of ability to mutate, 40 years if you're a professional. 20 billion year lead time on developing mechanisms to resist antibiotics because bacteria were fighting each other in the field before humans were even thought of. So they have an advantage, and we stay a step ahead. Example timeline, resistance in Staph aureus. When penicillin came out, all Staph aureus was susceptible to penicillin. Now like 1% is susceptible to penicillin, maybe at best, I should ask Jesse, but that's what most labs find, is the occasional kind of archived Staph aureus. And the resistance just accrued as we introduced things. So the very long view, if you want, you can't get longer than Earth's biogeologic clock, is that they have been doing this for 2 billion years, and we have not. And I think that there is something to be said about the idea that there's a bit of an addiction going on. So antibiotic successes changed medicine. They allowed chemotherapy to be survivable. They allow immunomodulation to be survivable. And everyone feels better and cozier and comfortable if the patient is covered. It's like covering them with a fuzzy blanket and giving them a stuffy because they have an antibiotic, so you feel safer. And I think that that is a trap. Because all the problems with antibiotics are actually things that are commonly underappreciated until your patient has that problem, or until you yourself experience that problem. And so the things I see, like allergy, cytopenias, nephritis, C. diff colitis is something that's really a big problem in health systems. Resistant superinfections, which I would call almost inevitable for people who are on broad-spectrum antimicrobials. And then we kind of go away from direct risk and into things that I would term more like ecologic harms, like the microbiome. What are we doing to people when we give them antimicrobials? We're just starting to scratch the surface of understanding that. And then population resistance risk. If you're using an antimicrobial in a patient and it has a differential effect on the likelihood of resistance in the population, should you be thinking about that when you're giving that antimicrobial? I would say yes, but we don't actually have great data or tools for that yet. I'm not going to talk about this too much. I'm just going to open the thought about microbiome because I think that we're just getting into it. But really, there's theories that basically the modern plagues of mankind, like everything that we're seeing in modern medicine that are challenges, might be related to microbiome shifting. Just as one example, the obese microbiome has an increased capacity to harvest energy from the diet. And there's very complex signalings between microbes and your gut immune system, if I can say it that way. And, just as a basic example, receiving antibiotics at less than 6 months of age is associated with obesity in the first 24 months of age across multiple studies. And if you think about it, that's why also livestock get antimicrobials for growth promotion. So the things that we do that we don't know the consequences of. So here's another case. I did a case from 1889. Now this is a kind of more current type of case. So when I talk with clinicians, I'll go over this. An 83-year-old man admitted from home with fever, delirium, hypotension, responsive to fluids, fortunately. Maybe a history of dysuria. History of prostate cancer, community-acquired pneumonia treated in the community 2 months ago. He's got a slightly elevated creatinine and a slightly high white count with the left shift. So I usually would poll the audience as to what they would like to give this man. We're going to start from the point of saying, okay, we want to treat this man for urosepsis. How do you decide what you're going to give him? I won't actually make you guys go through it, but I'll just say that in most audiences, we have takers for everything but number 4, okay? So what are we treating? So as a prescriber, what are you treating? If we actually get people to decide what they're treating before they treat, it actually improves antibiotic use. If we got people to actually record it when they actually order it, that would probably help more. Efficacy. So you're trying to treat the most common and most dangerous things that this man might have. You want to treat him well. Safety relative to risk. So what antibiotics on that list are relatively very effective but not as safe? Well, aminoglycosides. They would be very good for even most resistant organisms, but the safety profile isn't as good for an old guy with a bit of prerenal failure. Cost. Do we have to think about cost? This is where prescribers sometimes get kind of iffy. They're like, do we have to think about cost? I don't think about costs. I want my patients to get the best, most expensive things, right? So this is something that I think we have to keep part of the conversation, because if we can have equal efficacy and safety and improve cost, we can use that money somewhere else for something better. And so I actually think it's totally legit to put that on the table. And then the thing that's often missed is resistance. Is there any resistance implications to your choice? To be honest, I've probably lost most prescribers somewhere after safety. So this is something that's not part of the discussion. So in my head, I think about the escape key. So ESC, efficacy, safety, cost, and then resistance. And this is the kind of thing I sort of unofficially do in my head. I think, well, it's going to be E. coli, Klebsiella proteus. I kind of weight what I think the resistance profile is where I am by looking at my local antibiogram. What are my odds of success with these things? I think Cipro, it's too low in my center to rely on Cipro, so I'm going to look to ceftriaxone or carbapenem. If he has risk factors of recent antibiotic use, he had CAP in the community, what did he get? Did he get amoxil or did he get levofloxacin? So that also will impact your thinking on the quinolones, and you make a choice. Remembering that antibiotics are in fact unlike everything else we do in medicine for a few specific reasons. And you will get copies of these slides, by the way, sorry I didn't have them for them to print in advance. One big thing is resistance in ecology. So when you treat someone for their blood pressure, they take their pill, it impacts them, it doesn't impact anyone else. If you treat someone for an infection, they take the antibiotic, they develop an antimicrobial resistant organism that can spread within the community, it's actually a societal drug. So right away, you're starting with a difference. The volume of use is also very, very, very high. And so in hospitalized patients, about 50 to 75% usually get antibiotics. And in most audits, 50% of it is inappropriate to one degree or another or unnecessary. So high exposure. And then the other thing I kind of point out is that antibiotic therapeutics education, depending on the system that you train in, it can actually be kind of handled as we're going to talk about drugs, then we're going to talk about these antibiotics, and we're going to talk about chemotherapy, then we're going to talk about this and that. But there's about equal time given to, for example, cancer chemotherapy, which a very small number of people use, and antimicrobials, which frankly everyone use. And I think that we actually can do better before our healthcare professionals are done baking by giving them better antibiotic therapeutics education. And the final thing that we've kind of been going back and forth with is the idea that antibiotics are always positive or at least always neutral. So we have to recreate the medical culture that sees the risk-benefit ratio here as well as everywhere else. Because if antimicrobials were not needed in the first place, any risk incurred is unacceptable. If you did not need antibiotics and you ended up getting a colectomy for C. diff, that is a patient harm and it's unsupportable. And so we have to kind of get people thinking about these downstream effects when they're making their choices for antimicrobials and treat them with respect. Antimicrobial resistance, you guys are probably familiar with the report from the UK. 2050, antibiotic-resistant organisms will cause 10 million excess deaths annually worldwide, more than cancer and road traffic accidents in that analysis, causing the world's GDP to be 2 to 3.5% lower than it would have been had we not had antimicrobial resistance. And then CDC data suggests that 70% of the bacteria causing hospital-acquired infections are resistant to at least one first-line drug, causing us to use more expensive or more toxic or both second or third-line drugs. And so that background is basically a public health crisis, honestly. And we know that antibiotics use cause antibiotic resistance. And so on a macro level, if you live someplace like Finland, you're really lucky because you can do things like, you know what, we have too much macrolide-resistant strep, so let's stop doing that. And then they did. And then, wouldn't that just be satisfying? And then their macrolide resistance dropped. So that's pretty direct. That's a good demonstration. When you look at institutions, though, resistant organisms are more likely in institutions where we have concentrated antimicrobial use. So my shop, the University of Alberta Hospital, we have lots of ICUs and lots of transplants, lots of high-intensity use, and our antibiogram is the worst in our zone. It's just the way it is. And even within my shop, the ICU and the transplant unit have the highest rates of resistance of comparable organisms compared to, say, the family medicine ward or geriatrics. Well, no, geriatrics is pretty bad. Scratch that. But basically, all these things just are indirect but very strong indicators that you have to look at your own epidemiology as well when you're making decisions. And then on the final level, when I have patients with a really horrible multi-drug resistant organism, they either picked it up from another patient who's had it selected for by antimicrobial use, or else they themselves have had antimicrobial use that allowed this to become their organism. And so we're doing it. And when you look at countries, Canada's kind of in the middle. Basically, pen-resistant strep pneumo versus total antibiotic use, you can draw some pretty strong correlations at a very, very high level. And talking about consumption, the DDDs per inhabitant data do suggest that things are actually fairly tight overall in Canada, but especially places where there's community pockets that are potentially like underserved First Nations populations, stuff like that, tend to skew the data. And so that actually probably accounts for a lot of the variance you'd see on this graph. So the health system, I guess, disparities can make a difference to your consumption. And when you look at Canada versus other countries, we're sort of, hanging out in the middle as well. And I don't want to spend too much time on that, but just telling you that we're kind of normal. Practical points, though, bugs and drugs. So first, the drugs. Actually, antibiotics differ in their barrier to resistance, and so we should actually have some thought about that when we're making choices. Example, daptomycin, a new gram-positive drug. Quite expensive, but kind of handy because it's once daily. More daptomycin-resistant staph were generated in a single trial, a registration trial, than we generated vancomycin-resistant staph in more than 30 years of use. So this is our newest, biggest, best drug, and we're seeing some weaknesses already. And also bacteria differ in their ability to become resistant. So group A strep are pen susceptible. Full stop, end of story, not a problem. Group A strep also cause necrotizing fasciitis and can cause very severe disease, but they're pen susceptible. Whereas then you get your Pseudomonas species that can have many, many methods of resistance generation, or your Enterococcus species, which tend to be persistent, non-talented pathogens, but really hard to get rid of. They're like little ball bearings. They have a lot of resistance. So it's not actually easy. The content is not easy. So you do need expertise to help people negotiate these waters. And I know you're going to have a whole talk on measurement, but while we're talking about antibiotic use, how you measure does matter, and how you measure does impact how you identify your problems. And so this is just like some local data from a few years ago where we were only able to get expenditure data for a while, which was really frustrating because then you get all focused on money and not necessarily on best use. And when you look at the money, you're like, oh goodness, we have a big problem with Piptazo and vancomycin and actually Cipro. That's a lot of dollars in Cipro too. And a really big problem in meropenem, so that's the red line. But then when you switch the data to defined daily doses, you actually get an idea of the volume rather than the cost. And that's where you really start seeing that you have a ciprofloxacin and Piptazo problem, because those drugs being relatively cheap were kind of flying below the radar as an issue when you just look at cost. And so when you're trying to define what the best thing to do is, you have to look at all the different kinds of best. So money saving is nice. Appropriateness is at least on equal par with money saving when you're looking at stewardship, and defining your priorities becomes very important. And so from a resistance point of view, Joshua Lederberg, who got a Nobel Prize in '59, said the future of humanity and microbes will likely evolve as episodes of our wits versus their genes. And I'd have to say that that is exactly true, and that's exactly what's happening right now. So what can we do? We've already heard about some of the things happening in the push for stewardship. So the IDSA guidelines that most of us are familiar with were released a long time ago now, 2007. And there's national guidelines for hospital stewardship from France, Germany, Spain, UK, Netherlands, all from 2009 to 2016. In the US, California actually legislated stewardship in hospitals and got just like boom, you're going to do this now. So they had quite a rapid uptick of stewardship in their settings. And so it's a good place to look at for literature sometimes. And then Accreditation Canada introduced required organizational practices for acute care hospitals. They've been in place since 2012, and I will have some comments about that upcoming. So good antimicrobial stewardship, and this is like kind of a boring definition, and there's different definitions, but like most things that kind of seem boring, like vision or mission statements, they're actually important, and you have to look at each word in them. Ensures optimal selection, dose, and duration of an antimicrobial therapy, leading to the best clinical outcome while producing the fewest toxic effects and the lowest risk for subsequent resistance. That's what we're trying to do. Every single one of those things is an important thing to do. And when you think about preventative and curative medicine, on the preventative side, you want to preserve the antibiotics we have. You want to reduce unnecessary use. You want to change our approach to antimicrobials, try to break that addiction. On the curative side, we're actually needing some more stuff in the pipeline. So places that have had stewardship success have consistent high-level support for programs. They have regulatory changes that support the changes that have to happen. They have mandated programs, because if you make it a, hey, this would be a nice thing to do option, no one has time for that. They don't. They might mean well, but they don't have time. And investment in stewardship can save money for the healthcare system, but you have to make that pitch. Regulatory approach, incentives, risk diffusion for antimicrobial research development, decouple volumes of sales and income so that they don't stop developing new drugs. Because as soon as they develop a really good new drug, the first thing we do is restrict it. So this is kind of a disincentive to the pharmaceutical industry to do this, and so we have to address that as well. So I like to kind of step back and say, how can we steward? Where are the places we can steward? And to me, it's before, during, and towards the end of therapy. So before therapy, prescribers should think twice about whether or not antimicrobials are needed. And the thing that I think has really a tipping point is don't treat uncertainty. Either try for better certainty through rapid diagnostics, which are becoming more available, or monitor rather than treat. So I think that there will be some technologic support for this piece going forward. During therapy, narrowing as soon as culture data is available. So if you actually have a bug and drug, make sure that they're on the simplest, most targeted, most safe drug of the list. That is something that's commonly missed in acute care, because they're on something. The person reading the report looks down the list for the drug they're on, looks across to see if there's an S, and moves on. So do you need to treat that E. coli with Piptazo? No. Could you put them on ampicillin? You bet. would ampicillin potentially be a better choice, or cefazolin? You bet. And then towards the end of therapy, this is an area that I think might be a nice place to start. So both streamlining well on therapy to the most targeted treatment and best treatment available, and treating to cure and not beyond, because there's a lot of unnecessary antibiotic exposure that takes place at the end of a course where we're actually at that point probably treating inflammation. So if we can treat a ventilator-associated pneumonia for 7 days with excellent data behind it, so the sickest patients in the hospital on a ventilator and we can stop the antibiotics at 7 days, why is the patient on the medical floor getting antibiotics for pneumonia for 2 weeks? What if they get C. diff in the last 3 days of their course of treatment? What have we done to them? Nothing good. So actually, to me, after you've got the patient improving is an easier place to start approaching prescribers. Minimize unnecessary use starting there, because that's low-hanging fruit. They're already getting better. To me, and it made sense when I first drew this, and I think it still does, conceptual risk and benefit in antimicrobial use. I don't want to steward when someone comes in really sick. I want to give them the best possible treatment. But then I want to do everything I can to make sure they're on the most right treatment and not treat them for longer than they need. And as you go on therapy duration, you actually get increasing risk of side effects, adverse events, toxicity, selection and creation of resistance, and actually spread of resistance can all happen in that latter part of the antibiotic course. So, this has become a big thing. It was already mentioned that this is the 4th time that the UN has actually had a health topic at a high-level meeting. The other ones were HIV and I can't remember the other ones, but anyway, it's only the 4th time in the history of the world. So AMR is a big deal. WHO has been very active. The US under President Obama was several steps ahead. And in 2015, we've had the Federal Action Plan, building on a federal framework in 2014, and there's another framework document that's more current. And so we have lots of frameworks to work within, but we still have to do something. And so the classic thing people think about when they think about antimicrobial stewardship programs is the IDSA guidelines version. And so this is the stewarding where I think now in this setting, I'm kind of thinking of like a wine steward. For this particular situation, I would suggest pairing with this antibiotic. So you're trying to guide people to better choices in a very confusing list of options. And this, in a classic sense, is often a stewardship physician, usually ID trained, and a clinical pharmacist with ID training as well. And they're going around basically giving people advice. And with that, you need your clinical microbiologist, information system people, infection controls, and hospital epi people all on board. So that's the classic program. And the things that you can do are commonly broken down into prospective audit and feedback and formulary restriction, or combinations thereof. Prospective audit and feedback is usually unsolicited feedback, so either a lab report or antibiotic being ordered triggers a review, and then some advice is left for the prescribing team. This is a push, so you're actually leaving suggestions and they have to decide whether or not to take them. You track their agreement with your suggestions as one of your outcomes, and it allows for some educational dialogue. It's also a very resource-heavy way to go about things. Formulary restriction, on the other hand, is like, you can't have that. It's the COP. It's the antibiotic police. Like, you have to justify that you need that particular antimicrobial. So that's usually done at the level of formulary. And you have to be able to promote these, have a way to control within your healthcare system, and then give feedback as to what happens. And then there's a bunch of kind of targeted things that I think you can do that kind of straddle those a little bit. So inappropriate, for example, inappropriate use of IV drugs is something that can be a very effective thing to do within a pharmacy setting, is say, this person is on other oral therapy, this is a highly bioavailable drug, put them on oral, not IV. So you can do some things on a system basis as well. And when you look at what happens in literature with persuasion or enabling, so the audit and feedback, versus restriction, the effect size is actually fairly similar, a little in favor of restriction. And on meta-analysis, restrictive interventions had a bigger impact on prescribing outcomes at 1 month and on microbial outcomes at 6 months in the 2013 Cochrane review. In the newer review, it's a little bit less different. I have some references there if you're interested, but in the Cochrane 2017, interventions consistently improve treatment according to hospital policy with a lot of heterogeneity. Antibiotics can be reduced without affecting mortality, likely with reduction of length of stay. Feedback improves enabling interventions. So the the actual provision of feedback to your prescribers and that loop is very important. And restriction can delay treatment and impact culture negatively depending on how you carry it out. So you actually might get more pushback from just coming in like a big, heavy and restricting things. So there, you have to kind of weigh the risk-benefit of each approach in the setting that you're going to be dealing with. One other thing I want to pull out, which was very nice finally, is that we've always had problems showing that antimicrobial stewardship improves resistance because the data has been patchy and all over the place. And then some nice people put together a systematic review and meta-analysis for us. And I love those people, and this is the reference. In 32 studies, there was a 51% reduction in multiple drug-resistant gram-negative colonization infection, about 48% reduction in ESBL, 37% reduction in MRSA, 32% reduction in C. diff. And they really point to the fact that we have to partner with infection control. So bundled approaches are really the thing that you find having the best data. Now, Alberta, what are we doing? We have one healthcare system. We are one. And we failed the stewardship required organizational practices. The challenges I thought were very instructive. One thing was that we had our accreditation visit a few years ago, and so the whole thing was quite new. And we were just trying to get everyone on the same page talking about it, more or less, and had like committees everywhere, but the degree of development of programs was a little bit less sure. And to me, the things that I would have tried to do differently had I had any power or influence, which is kind of a problem. If they just made me emperor or something, it would not be a problem. Need high-level support that's accompanied by action. So just saying this is a good thing and we have to do it isn't really enough. Saying it's a good thing and we have to do it and you have to tell me how you're going to do it and you're going to have to report back to me how it is done makes a difference. Mandating hospital-level programs. Hospitals, we have hospitals that have a lot of conflicting demands under the, relatively fresh structures that have been put in place. And everyone was trying to get people to do stuff at the same time. So, you have to have a quality program, and you have to have this, and you have to have that. So there was a lot of stuff coming down from middle management to the beleaguered front line, and it's very hard to prioritize people's time to address things properly. So having a thoughtful approach to figuring out, where this sits in the priorities, and maybe giving extremely granular guidance, like in an acute care setting, what does your hospital need? Like, what is the minimum you need to have? Because if you just say you need to do this, very hard. You have to groom personnel with expertise and create an intra-supportive community of practice to improve the expertise. And figure out synergies and relationships. I'm still grappling with this because things keep on changing. We've had a lot of leadership changeovers. It's like Game of Thrones, like there's beheadings every couple of years. And you're like, oh, that person was on board and we're about to do something and they're gone, so let's start over. How many business cases do I have to write and have meetings about, right? But figuring out the synergies and the relationships, especially with key players like infection prevention and control. Some places stewardship is infection prevention control. Other places it's like an ally. And quality and safety. So if there's a robust quality safety infrastructure, stewardship by its nature is about quality and safety. And do you want to dovetail with that? Do you want to actually become part of that? Do you want to be your own freestanding thing? These are important things to think about. So this is just our Antimicrobial Stewardship Program site on Alberta Health Services. It's the outward-facing one, so it doesn't have all of our data on it, but it has some of the tools that we use. And when we look at what Accreditation Canada wanted, now this was as of 2017, it's for inpatient acute care, inpatient cancer, inpatient rehab, and complex continuing care. So it expanded. So now those latter places are also included. And the guidelines, and it basically is saying that this is important and you have to have a program. And when you look at how they're going to evaluate, this is from their website, organizations are encouraged to tailor an approach to stewardship that's consistent with their size, service environment, and patient population, and establish processes for ongoing monitoring improvement. And so they're actually being clear that what we see in the IDSA guidelines might not fly at every single place, which is good because we don't have that for every single place. You need collaboration between the right people. And so in my zone, we have a group that's a committee that has all of the people that the guidelines suggest, and then we have site champions at the community hospitals that we try to liaise with. There's some drawbacks to that, but it's a start. And when we look at what they actually do, they say there has been a program implemented. There are people who are accountable for the program, that it is interdisciplinary, and underlined there as available and appropriate. So having those people around as a resource might not mean that they have to be on each site, and that you have interventions, and then it gives a list of all the classic interventions. And I think, I mean, for you, I'm not sure if you have an amalgamated formulary yet, but that's a good first place when you're looking at stewardship, defining a formulary with restrictions or guidelines for use, and deciding what should be restricted and what should be a guideline, and deciding how that's going to actually be enforced is actually a great opportunity while you're having a period of change, which otherwise is usually not a great opportunity. And then their minor tests of compliance, I don't think is at all minor, because the program is evaluated on an ongoing basis and results are shared with stakeholders. So they're reporting. What did you do? What did you do? So my post-accreditation thoughts. One thing is that a committee is not a program. And no matter how many times you try to say it is, it isn't. A program is actually people who do things. And that was, I think, a big problem for us, because we were in varying stages of sophistication of actual program infrastructure at that point. The other thing is, a program isn't a program unless everyone knows it's a program. Because they go to every site and say, so, tell me about your antimicrobial stewardship program. And if the response is, what? You fail. So there's a lot of sites that have visits, and trying to make sure every person that accreditors might speak to when they come through for accreditation know that there's a program and what it looks like is a lot. It's a lot. Closing the loop, the one thing that I find happens is we say we're going to do things and then we do them, but then we forget to actually take that back and finish the quality cycle and say, how does this impact how we're going to go forward and share the results? And so closing the loop is something that doesn't come naturally to everybody, and it's something that we have to make very important. And I actually think that Accreditation Canada is going to be the thing that gets stewardship rolling. It's just slightly painful along the way. So I'm going to be wrapping up pretty quick here, but defining direction. So things that you're going to be talking about over the next 2 days. Adequate data, surveillance of use and resistance. What kind of data can you get for every site? Who at the site has access to that data and knows their local numbers? Who's providing oversight and interpretation of that data? Computerized order entry, will that be a possibility? That's a great stewardship tool. It decreases your infrastructure needs. We keep on almost getting an EMR, but now we're actually probably going to, so I'm excited about that. Moving beyond education and guidelines, because you can make guidelines all you want. They don't actually change practice that much. There needs to be supported personnel and infrastructure, and it can't be volunteers, because well-meaning volunteers have a lot of stuff on their plate. And then who leads the charge? Who has the time, the resources, and the mandate to actually make it happen? And so thinking out loud a little bit about stewardship models, I just did this last night because I was trying to grapple with what I'm doing actually. So you can have, say, pharmacists and physicians are key personnel. And you can either have distributed responsibility, so you make all prescribers and all pharmacists responsible for stewardship, or you can have an expert team of an ID pharmacist and an ID doc, and you can have variations in between. And what do we know about that? So to me, the classic ASP team is dedicated expert is your team. Distributed responsibility on both sides, to me, would imply a system approach, but it's unsure who leads that. It's unsure how you can add to to-do lists and actually get things done. I think if you were exploring that, you'd really have to look at your partners within the infrastructure of the healthcare system. There is some literature on stewardship physicians providing backup to general pharmacists. And again, this is mostly focusing on acute care, but there would be analogies within the community as well. And to me, that kind of a thing might work very well if you really define your best targets and you really have a defined boundaries for what you want that program to accomplish, because expertise in an area gives your pharmacist a lot more comfort in dealing with prescribers. And so you have to be careful with that. And then pharmacist-led stewardship, there's some centers where they don't have ID docs, and they basically have an expert pharmacist working directly with prescribers. And there are, again, places where that has worked very well. I won't go into, so the who is very important, and support and clarity in the roles is very important. And so I won't spend a lot of time on this, but this is just some references of places that have done different types of, experts and like a pharmacist expert with prescribers in general, or ID expert with general pharmacists. So I think that they can likely all work. I'm not sure if the system approach can. I think you need a person who's actually carrying the flag. So our future steps are still establishing stewardship within our systems. The parallel is infection control. We're behind where infection control is, but in 20 years we should actually have programs people can recognize for sure. And focusing on cost savings can make you a good business case, because if you save 10 to 20% of the antimicrobial budget, you can pay for your personnel. But you can't save that every single year, because if you save that every single year, you start killing patients at about year 2 or 3, because they need those antibiotics. And so you can get the start up, but you have to justify the continuation on the basis of quality. And what you measure is important. And then the final concept, if you're not familiar with it, is one that we like to bring up in our stewardship discussions is, how there's the carbon footprint? You think about your carbon footprint and how everything you do contributes to that. What is your antibiotic footprint? Everyone in the system, be they a patient or a physician or a pharmacist or a nurse or an ICP, actually everyone who's ever come into any contact with antimicrobials has an antibiotic footprint. And so if you conceptualize that every time you are prescribing, for example, you might think, what am I doing to my antibiotic footprint right now? Am I supporting the greater good in what I'm doing right now? So to counter AMR, we need all of surveillance of use and resistance, infection prevention, stewardship programs, and whatever the construct you end up with, it has to be a formal and resourced accountable team who will support all the antibiotic users and best practices for prescribing, really keeping the focus on the community of the current and future, and keeping the hall for our grandkids. And that's it.
So we have a couple minutes for questions. I would like to take a moment to remind our WebEx audience that there is not a call-in option. It is by chat, so don't try to dial in. Just use the chat option when you are joined on the WebEx. So from the audience, if you can just raise your hand. We have a microphone on the far side, and I have one on this side if you'd like to ask a question.
Oh, there's a question over here.
Hi, I'm Sherry. I was just wondering, with the program in Alberta, who is accountable? And for those who don't follow the program, what is the fallout for them?
You just defined my problem. So currently the program sits provincially under pharmacy medication management. And so all the pharmacy processes are what we bring to bear when we're trying to improve use. The problem is there's always some prescribers who really aren't impressed by that. And the intra-site variation in whether or not there's teeth to restrictions, for example, is incredible. And so there's tremendous site-to-site variability, including some sites that eventually had a really jerky surgeon yell at everyone 10 years ago, and now they never say anything to anyone about antibiotics. And so a lot of it turns out to be issues of local culture change, which is very challenging. My personal preference would be to steer things to actually either be standalone or with quality and safety, and use quality and safety as the kind of administrative locus, and interact obviously with pharmacy and others, because I think that that actually puts the responsibility more squarely where it should be, which is quality and safety, and also might actually help buy-in from prescribers who aren't always impressed when pharmacy tries to make them do things differently. So that's like an incredibly key question, and I don't actually have the right answer yet. I'll let you know. It's been, we keep on trying things and then going, well, that didn't work. So we're just thinking critically about that right now.
Thank you. Other questions?
Maybe
Great.
they're hungry.
We have something before lunch, but if that's all the questions, do we have any questions from WebEx? No questions from WebEx. Oh, question? There's actually a question behind you. Oh, there we go.
Oh, okay.
Hi, David Torr. I'm a medical health officer in the system here in Saskatchewan. I like the introduction part and the rest of the presentation as well, and it's very important when we talk about the partnerships. And one area that we certainly must keep in mind, and this is just a comment, especially for us in Saskatchewan, is that we are a farming community, and the antibiotic use in the farming community is a very key component to this. So when we look at the partnerships down the line, we shouldn't just look at the patients, the hospitals, and the communities, but also specifically what goes on with the farming community.
Yeah,
Thank you.
I think that's a good point. And I think one thing I find is that appreciating the concept of stewardship as a food producer probably does impact someone's own individual approach to antimicrobials in the health system as well. And so when you're thinking about public-based education, there's kind of a bit of an opportunity of a 2-for-1 if you're looking at, agri-food use of antimicrobials, because I think that the same people actually have to develop a stewardship risk-benefit ratio understanding within the health system as well. So I think that's a good point. Okay, thanks.
And Dr. Saxinger will also be part of the interview panel that we have this afternoon at 3:45. So if you, chat with colleagues over lunch and think of a question, there'll be other opportunities for you to provide questions. So I'm going to tell you about lunch, and then I'll tell you about a brief activity that we will do before lunch. We have an hour for lunch. It will be over there, and I'm sure you can already smell its deliciousness. And I'd like you to reconvene at 12:45. So we're doing this a little bit earlier than some traditional lunches. If you requested a special meal, please see the carver, the staff member, because there is something there for you. So now you're dying to know what the special pre-lunch activity is, and it is that we would love to have a photo of all of you. And we thought that a nice place to have it would be on that grand staircase that's just out of these doors. So I hope that you will indulge us in doing that, and we can, then it doesn't matter quite who's tall if we're on the stairs, and then we'll come back in here and you can have your food and bring it back to your seats. So thank you very much. So Bob will lead us out.